you all for joining us today. I'm Jen Sanders. I'm the Director of Clinical and Medical Affairs here at Senzyme, and we're honored to have two outstanding experts with us today who will be discussing the new ESAIC and ESPA Pediatric Neuromuscular Block Guidelines and how they translate into everyday clinical practice. Our first speaker today is Dr. Debra Faulk. She's an Associate Professor of Paediatric Anesthesiology and Board Certified Pediatric Anesthesiologist at Children's Hospital of Colorado, where she serves as the Director of Operations for the Division of Pediatric Anesthesia. In this role, she oversees 35 anesthetizing locations across 3 campuses and leads a team of nearly 100 anesthesiologists, anesthetists, residents, and fellows. Her research focuses on the monitoring and management of neuromuscular block and pediatric anesthesia, and she has led the efforts to implement and standardize quantitative neuromuscular monitoring in clinical practice. She'll be followed by Dr. Nicola Disma, a senior consultant pediatric anesthesiologist and professor at the University of Genova in Italy. He serves on the research committee for the European Society of Anesthesia and Intensive Care and the executive board of the European Society of Pediatric Anesthesia, and chairs the Pediatric Anesthesia Research Network. His research focuses on anesthesia-related outcomes in children, and he has led several international clinical research initiatives in pediatric anesthesia. You all could join me in welcoming Dr. Faulk and Dr. Disma. Dr. Faulk, the floor is yours.
Are you all able to hear me okay? Yes? Okay. I'm gonna get rid of this one. All right, so thanks everybody for coming and welcome. We'll see if more people trickle in as we start, but really we're talking today about how do we raise the standard with these pediatric neuromuscular guidelines that have now been published this last week out of Europe. And I'm housekeeping, so I have been provided with research equipment for some of my studies that I've done on loan from Senzyme, and have received an honorarium for my time preparing this talk today. But what I really want to do to begin this is hopefully kind of set the stage to talk a bit about the guidelines. And in order to do that, I thought it was good to go over a little bit of kind of how we've practiced in the past, maybe some newer ways or things that are influencing our practice, where we go from here, which is ultimately going to be the guidelines, and then maybe some final thoughts. But we'll start off with just how have we approached and monitored neuromuscular block in the past? And I had done this. I'm sure everybody in this room has done this. We've based our decisions on time-based management. We've looked for clinical signs of strength, things like head lifts, grip strength, and probably most all of us have one of these things in our drawer and have used it at some point in time, a peripheral nerve stimulator. How many people have used one of these? Yeah. So pretty common. Just to get us all on the same page in terms of our nomenclature here, this probably looks familiar to everybody. When we are using one of these peripheral nerve stimulators, I want to emphasize that is a qualitative assessment that we are basing our judgment on what we see or feel. So as you know, you can get 4 stimuli to a nerve. It's going to contract the muscle, and you're going to either see or palpate the muscular response and determine the strength. And so if we look at this, we can count how many twitches in that train of 4 assessment we do that gives us a train of 4 count. We can look at the decrement of strength that we call fade and assess that. If we've got a first and a fourth twitch, that's where we get that ever-present train of 4 ratio. So we compare the first to the fourth. By example here, it would be 0.4. And we know today at least, we currently accept adequate recovery as a train of 4 ratio of 0.9. All right, so that's probably what it looks like for you in your practice. And you can see there why this is difficult. So who thinks that patient is adequately recovered? Train of 4 ratio of 0.9 or greater. Okay, who thinks they're not recovered? And what do you think the train of 4 ratio is? Hard to say. So I put a quantitative monitor on the other side, and that twitch response was actually a train to 4 ratio of about 80%. So it's really hard for us to tell, and we've known this for decades now. So V.B. Mokinson, back in 1985, looked at our ability with human senses to detect minimal levels of block. And he really found that within this zone of 0.4 to 0.9, we really can't tell whether or not there's fade. And so in order to do that in minimal levels of block, we really need quantitative devices. Otherwise, we're going to look, maybe presume that our patients are strong enough, but they could still be really experiencing some significant weakness. And this is borne out in the studies, so we know it in adults, and it happens in kids too. So multiple studies over the past several years have shown that kids do experience residual block, probably in the same rates that adults are experiencing. The reports are saying anywhere from about 20 to 50% is what's been seen so far. And in 2023, we know that in response to this in adults, and for us in children as well, guidelines came out from both the US and the European societies. And it was interesting to me that these guidelines, the work that was being done by the task forces, were being done independently. So neither really knew what was going on with the other one. They were actually published, though, about a month apart from each other. And despite not having any knowledge of the other group's work, the recommendations that came out from these two documents were largely the same. And I think that really speaks to the strength of those recommendations. So really what they both emphasize is we should be using quantitative monitoring. We should be doing that at the thumb rather than facial muscles. And we should look and see that our patient has returned to a train to 4 ratio of 0.9 or greater before we extubate them. And they also gave some recommendations on what we should be using to antagonize block if we need to at the end, and we'll speak to that in just a moment. But we're now 3 years into this in the US and Europe for that matter, and so how are we doing? And within the US, there have been a couple of surveys. This is one that came out from the Society of Ambulatory Anesthesia. Just this last year, they surveyed their society. And interestingly, what they saw was about 85% of their respondents said, yep, we know that there's guidelines out there. But only about a third of them said, yes, I follow them and I check the train to 4 ratio and make sure it's 0.9 before I extubate. And despite that, about 2/3 of them said, I am completely confident in the path that I have chosen in my strategy for monitoring and managing neuromuscular block. So there's a bit of a disconnect there, but they did say, well, there's a lot of barriers for me doing this in my practice. And so you can see, sorry, it's a little blurry, things like, I don't really see the value in doing this. I don't know how to use it. We're not educated. It's too burdensome in my busy practice. But really the top two for them that came out from their membership was, I don't have any equipment and it's too expensive. All right, the ASA has also done a survey of its membership. This is some information ahead of publication, but they found the same thing. About 85% of their respondents said, yep, we know that there's guidelines out there. But despite that, more than half of the respondents said, I still use a peripheral nerve stimulator. I'm still monitoring facial muscles. And I usually don't confirm that my train to 4 ratio is 0.9 or greater. Interestingly, they also said the biggest problem that we have is we just don't have access to these monitors. So at least within the US, it looks like access is really one of the big impacting factors in terms of adoption and uptake of quantitative monitoring at the present. And so, yes, there are many barriers to us putting this into our practice. Cost and availability we just looked at. There's lots of other things. And these are not new. They existed before 2023 in the guidelines. And for the most part, they're also not really unique to neuromuscular blockade and monitoring. So in-grade attitudes, we saw that. I don't think I need it. I don't believe that it's of any value in my practice. We're not educated. We don't trust this technology, and that can happen with new technology that comes out as we're learning it. It's too much to put into my busy practice. But I think one thing that is kind of unique to the moment and to quantitative monitoring or neuromuscular blockade management is to Gammadex. and how that has really impacted our practice, the way we look at monitoring and the need for it. And so Sugammadex is kind of the new kid on the block, introduced in the US at least in 2015. And for us as pediatric anesthesiologists, if you weren't aware, it's now indicated or has FDA indicated dosing for all ages. And that really follows that two-tiered approach that we see in adults. So if you've got a return of T2, you're gonna give 2 milligrams per kilogram. If you've got only post-tetanic twitches, you're gonna give 4 milligrams per kilogram. Just to remind everybody, there is no indication yet for that 16 milligram per kilogram immediate dose if you need it. Doesn't mean that we don't do it in pediatric practice, but we don't have the indication for it yet. And I think the thing to know about this is all based on quantitative monitoring in endocrinologists. That's where we should be monitoring in order to know that our dosing is correct. And for me, it kind of is, I call it my Google Maps theory. I think Sugammadex absolutely can be efficient, effective, and get us where we need to go. But we can't do that unless we know where we're starting from, and it's based on quantitative monitoring. And this is actually nothing new. Back in 2013, Kotaki did a study where they wanted to know if people practice and base their decisions on clinical assessments, what was the rate of residual blockade going to look like? And they compared Sugammadex, neostigmine, or no antagonist, meaning by my clinical judgment, this patient is strong enough and I don't need to give them anything. And what they saw was, yes, Sugammadex was less than neostigmine, less than I think my patient is already strong and I don't need to do anything, but this number is not 0. Sugammadex is not that silver bullet that we think it is that will be effective if we don't monitor. And interestingly enough about this, they used a modality of monitoring called acceleromeography. And if you've ever seen it, it's a little tricky to use, but the thing about acceleromeography that we have to look at when we're looking at these numbers is it has a tendency to overshoot baseline. And that means when you have a patient that has not received anything yet, it can give you numbers at baseline that are much higher than 100%. That's impactful because when we talk about 0.9 being the recovery threshold, that's 0.9 of a presumed baseline of 100%. So if you're above 100%, it's going to be 90% of your baseline. And this is actually a text conversation that I had with somebody who was using acceleromeography, and their baseline, I don't know if you can see that, sorry, it's a little bit light, was 138% before they started. And I said, that's great, let me know what it is when you're done. I would love to understand that. And they said at the end, it was exactly 100%. Yay, we did a great job, our patient was strong enough. But their baseline was 138. So what does that mean? If your baseline is 138 and 0.9 of baseline is adequate recovery, your adequate recovery is actually going to be 124. What they got was 100, and what that represents from a baseline of 138 is 0.7. So that patient was actually still quite weak at that point in time when they extubated and went to the PACU. All right, and if you look back at Kotaki's study, knowing that overshoot phenomenon, some people will suggest if you're using AMG and you don't normalize it with those calculations, you should at least be considering your threshold is not 0.9, it's 1.0. And when they went back and looked at that, you can see the incredible jump in numbers that residual neuromuscular blockade took in terms of the rate that they were seeing. So far from 0 here, potentially they had up to half of their patients that could have been experiencing residual block. All right, and this is very concerning in my mind because in 2021, we surveyed our membership here, and what we saw was that those who were early out of training, meaning they had come through training when Sugammadex was introduced, they said, yep, that's the agent I prefer. So most of them were reaching for Sugammadex, but when they did that, they were really not monitoring. They were monitoring even less than the baseline that was reported. And despite that, we were also seeing Sugammadex failures. People were saying, yep, I'm seeing Sugammadex fail. So we're using Sugammadex, we're monitoring less, and we're seeing failures. And this is a very nice review, case report and review that came out last year that looked at reports that we are seeing in the literature of C-Gamedex failures is we're mostly in infants. And kind of the theme that they saw across these cases were three things. They were seeing rocuronium overdoses, and keep in mind that for infants where they were seeing this, the ED95 of rocuronium is 0.25 mg per kg. And we consider an intubating dose, right, 2 times the ED95. So they were seeing overdosing of rocuronium in these patients, inconsistent or lack of monitoring, certainly lack of quantitative monitoring, and that was resulting in inadequate C-Gamedex dosing, most likely, leaving these patients weak. And sorry if this is a little bit small, this is just an excerpt from one of the tables showing what their multiples of ROC were for intubation for the case, that they really weren't monitoring consistently, and then the doses that they gave of C-Gamedex. And you can see, especially for the cases, these were massive overdoses for these patients. In one case here, that's like 5 RSI doses for this patient. This case lasted for 4 hours, so that's a lot of rocuronium. And with that, they didn't monitor. They gave 4 milligrams per kilogram, and not surprisingly, this patient was weak. This patient here on the end may have got a more reasonable dose of rocuronium, but for their monitoring that they did with 1 PTC, they gave only 0.5 milligrams per kilogram, so much less than the FDA indicated dosing. So I think overall, the introduction of C-Gamedex has resulted in less monitoring, and it's made us a little bit sloppy in terms of dosing all of our meds with neuromuscular block and antagonism. But what the authors recommended is when you're taking care of patients who are less than 2 years old, really we should be thinking of a few things. Limit our induction dose to an actual intubating dose at 0.5 mg per kg, especially for elective cases. Use quantitative monitoring. Watch that they have sustained recovery, and that may mean extended observation in the PACU. They recommended for at least 60 minutes. And we really need to be watching these patients vigilantly, because if we're not monitoring them correctly, we at least need to know that they're stable and not struggling in PACU. All right, and I do want to just touch on the barrier that we face in terms of our kind of ingrained attitudes with neuromuscular blockade use and monitoring. And these are actually things that I've been told by people personally when I ask them, you know, what are your thoughts on monitoring? Do you think you're going to monitor? Why wouldn't you monitor? And so it's out there and it's real. And I think that there's a couple studies, this one most recently, that really underscore that. So this group looked at usual care. The teams were working however they wanted to in terms of their management and their choices. And they wanted to see what the rates of residual block were going to be. And kudos to this group. They actually did a pretty good job of monitoring. 70% of the cases had monitoring, 65 of which had quantitative monitoring. That's pretty impressive, actually. But they still saw residual block, 10%. They did say, well, qualitative definitely was better than quantitative monitoring in terms of helping that risk of residual blockade. But I think that what was most telling is that at the end of everything, they were telling the teams if the kids had a train to 4 ratio of less than 0.9, and only 8 of 9 of the teams that they told elected to do anything about it. Most of them just said, we're fine, went ahead and extubated and didn't give any antagonists to those kids. So I think that the unlearning that needs to happen for us to be successful is real. And some people will say residual block doesn't really matter. Well, these are a couple of studies that came out over the last few years. The top one out of Joe Tobias's group at Nationwide. And they asked the question, if C-Gamedex is that much more effective and residual block is so bad, what happens if you look at C-Gamedex versus neostigmine for reversal? Are you going to see more postoperative pulmonary complications with one agent or the other? And this was a very large retrospective database study that was cohort matched. And what they saw was surprisingly no difference. But what they said was they didn't factor monitoring into these patients, so it's somewhat hard to tell. And it may be that looking at the levels of neuromuscular block in these patients is probably more impactful in terms of preventing postoperative pulmonary complications as opposed to which agent you're using to antagonize them. This study by Scheffenbilcher looked at infants, and they actually did see that there was an issue when you're using those high doses of neuromuscular blockade in postoperative pulmonary complications. And we just saw that in the case reviews in the literature. But they said high-dose neuromuscular blockade, and that was defined as greater than an ED95. And we just showed that some of those kids were getting multiples of 20 times. But greater than 2 times the ED95 was associated with an increased risk of pulmonary complications afterwards. That was magnified if you were young, less than a year old, if you had a high ASA status, or if you had a shorter length of surgery. And there's been multiple studies that show if there's a shorter length of time between your last neuromuscular blocking agent and trying to antagonize it, you do see more residual blocking issues. So not too surprising. And this paper came out just in the last month that I think really underscores kind of our practice and the risks here in terms of how we're managing block. This was a study that looked at what has happened to our choices in rocuronium dosing with the introduction of Sugammadex. And they saw that introduction in their institution happened in September of 2016. Prior to that, rocuronium dosing looked pretty stable. They didn't really see a whole lot of change. But with the introduction of Sugammadex, they saw the rocuronium dosing really rise to a point of about a 45% increase. Sugammadex was obviously going up in parallel with that, but what they saw with that was that there was an increase, a dose-dependent increase in postoperative pulmonary complications with those changes. And it was greatest if they didn't antagonize the block, greatest if they didn't monitor, could be attenuated with either qualitative assessment or Sugammadex, but the only thing that got rid of it was if you use both Sugammadex and quantitative monitoring. All right, so where do we go from here? Obviously, we're going to go to the guidelines. Nicola's going to tell us all about that in just a second. Spoiler alert, he's going to tell you need to quantitatively monitor. But if we're going to do that, if we're going to use quantitative monitors, how are we going to get there and how are we going to do it? So what's out there? 4 types that you probably see mentioned in the literature if you peruse it. Mechanomyography is the gold standard that we talk about. Not used in clinical practice. It's really hard to use. It's big, it's bulky. We don't even have access to commercial devices. So we mention that only in terms of historical content of being the gold standard. But really right now what we have available to us are acceleromyography and electromyography. Kinemyography is out there. I don't see it used as much, especially in kids. But AMG and EMG are the 2. And this is a tough watch. If anybody's ever used it, it can be a little bit finicky. But it works by placing that sensor on the thumb. You stimulate the nerve, adductor pollicis contracts, and it measures tissue acceleration. And there's a few problems with that. This unit is pretty finicky in terms of it really requires that sensor to be placed in the motion of the thumb. And we know that the motion of the thumb can go in many planes. There are new models that have tried to account for this, but you still have to deal with setup time, calibration, signal stabilization, and that TOF overshoot that we mentioned. And beyond maybe the issues that you might have in acceleromyography, this is data from a study not yet published, but that came out of our institution in collaboration with Johns Hopkins. And what we did was we looked at the simultaneous measurement of AMG and EMG, or electromyography, in children on the same arm. And what we found was that overall, these kids had kind of had a lower bias towards AMG recovering faster, of about 3.8 seconds. And so maybe not clinically significant, but when we broke this out into age groups, what we found here is in our youngest patient, 12.2 seconds bias to AMG recovering faster. So that's pretty significant, can be clinically significant, and this is normalized data. So if you're out there in practice using AMG that is not normalized, this might really be amplified, and those kids, those youngest patients, could really be at risk. But overall, I think that the biggest barrier we face in pediatrics is that AMG requires free movement of the thumb in order to measure that tissue acceleration. So we all know our patients are positioned with their arms tucked to the side. Makes it incredibly difficult to use AMG technology in most cases. So I'll pivot to EMG, which is based on compound muscle action potentials that it's measuring. And so it doesn't require a free thumb because it's not dependent on tissue motion. And this is a really nice way, I think, that potentially quantitative monitoring can be incorporated and integrated into pediatric practice, even with the barriers that we have. There are some things still to think about with EMG because it's based on compound muscle action potentials. There can be electrical interference in the OR. It does require these specialized sensors that go with the unit, so there's a cost in terms of disposables and their use. But overall, I think that it's a more viable option when we're talking about can we routinely monitor kids quantitatively in the OR. And this is a series of studies that came out of Nationwide Children from Joe Tobias's group, just looking at, actually, is it really feasible to use these monitors in kids? And he looked across all ages just to say, can I put the sticker on? Can I get a good baseline? Can I get a recovered TOF ratio? And he found yes. Anywhere from 17 years old down to small babies that were less than 5 kilos. I think that the smallest patient in this feasibility study was 3 kilos. So it is possible to use these monitors on children of basically all ages. All right, so kind of the takeaway things to think about historically, residual weakness is real in children, and we really need to be looking at, can we quantitatively monitor them to detect this residual weakness and hopefully prevent the adverse outcomes that might happen. EMG looks like it's definitely feasible and doable, and hopefully practical in practices to be an opportunity for routine quantitative monitoring in these kids, and especially using them despite the fact that you're using Sugammadex. Sugammadex dosing is based on quantitative monitoring, and we really need it to assess that we're getting kids to the place they need to be. Neonates and infants, from what I just showed you, are probably our patient population at greatest risk, and we need to think about that in terms of the consequences of managing these kids. But I think that we really are, the guidelines, we kind of sigh of relief that finally they're out, but I think that really this is kind of the beginning of the journey in looking at how we can potentially implement quantitative monitoring in kids. All right.
So we take question again.
Yes.
Okay, thank you very much. Do you need microphone? Can you hear me well? Yes, are you enjoying the Italian meal we provided? This is what I specifically requested for today. The Italian meal, please. I hope you have. Okay, my name is Nicola Disma. I work in Italy, and Debra made my job very easy because she fantastically presented the overall picture of neuromuscular blocking agent use and monitoring. So my role will be presenting the guidelines which came out literally a few weeks ago. And honestly, this is the first conference where we are officially presenting European guidelines. It's surprising that you are presenting on the other side of the ocean. This is the hospital where I work. It's located in Genoa. I represent the European Society of Anesthesia, ESAIC, the European Society of Pediatric Anesthesia, and I'm glad to be the chair of something which I've always had in my heart, which is the partner, the Paediatric Anesthesia Research Network, which is funded by the European Society of Anesthesia and Intensive Care. It's basically a platform where we have connection between centers mainly in Europe, and through the network we are running several trials. So it's a nice network where people can throw good ideas, and wherever they need big collaborations, that's the place where they can find easily collaboration. It's working pretty well. Okay, these are the guidelines you can easily download from the European Journal of Anesthesia. They are open access. As I told you, they are the result of a collaboration between ESAIC and ESPA. They are called 2025, but they came out in 2026, actually. As you know, there are some rules for publications of guidelines, which are still a little bit weird for me, because journals love publishing at the beginning of the year, because then they will be cited in the same year, and it push up the impact factor. That's okay. So in the next 20 minutes, I'm going to present why we wanted to do the guidelines, with who, how, and which is the current situation of using neuromuscular blocking agent and monitoring in Europe. So why we wanted to do the guidelines? Again, this was exactly immediately after the publication of the adult guidelines. As Debra said, the American and European community societies published roughly at the same time 2 guidelines, and we got many emails from members saying, oh, we have adult guidelines and we don't have anything on the pediatric. And it was specifically written in the guidelines that they, all patients below the age of 18, they were completely excluded due to that lack of evidence, which is not exactly correct, because some evidence exists, and this is why we wanted to write our guidelines. So the aim was to provide an update on the use of neuromuscular blocking agent. Of course, there's a little bit of politics inside always. We are not going to dictate clinical practice. We are just providing you which is the current evidence and the general guidance. And of course, the aim will be to implement the guidelines locally, the very same way we did for the neonatal and infants airway management guidelines. So go through the guidelines, understand your local situation, implement locally, and implement what is missing in your daily practice. And actually, to be honest, it was also a very nice opportunity to see which were the gaps in knowledge in order to establish new trials for the future. And we already did something quite interesting. So with whom, as for the other guidelines, we had to follow the ESAIC regulation. We had SOPs for guidelines, which they work pretty well. We applied in 2023. We went through the guidelines committee, and then we wrote a memorandum of understanding between the 2 societies, the adult and the pediatric society. So we created a task force, which was formed by European and non-European members, and the members were also collected through the partner, the Paediatric Anesthesia Research Network. We were not all experts in neuromuscular blocking agent. We are all experts in pediatric anesthesia, and we contributed from based on the literature evidence, but also based on our daily practice. Okay, these are the usual suspects. You will recognize some of the faces from this picture. I mean, it was a nice journey at the end of the day. Okay, how? Methodological support from ESAIC. We had 2 methodologists on board. This is quite important to make sure that the methodologist was strong enough. Logistic support from the guidelines department, approved initially by the editor-in-chief of the European Journal of Anesthesia, so we informed the editor-in-chief that we were writing the guidelines, and well, that's okay. So the criteria, they're always the same, so we wanted to have strong guidelines, meaning that we went through all the existing literature and we did a proper systematic review of the current evidence. So we developed this multidisciplinary team according to the SOP guidelines for the European Society of Anesthesia. And of course, the recommendation should be logically aligned with the supporting evidence. This is actually what we do in our journey for the pediatric guidelines. So overall, we started in 2024. You remember we applied in 23. We did the search. We screened all the papers. We extracted the data. We did systematic review, and then we had to go through Delphi rounds. And of course, we try to accompany the guidelines with an editorial in order to make a little bit more digestible, since this is quite a long paper. So we met several times, and at the end, today in Denver, we are presenting officially the guidelines. So as you know, the way building guidelines is always more or less the same. So we created initially some clinical questions which we wanted to answer. So question one is muscle relaxant necessary to facilitate tracheal intubation? And within this question, we developed 8 PICOs. Question number 2 was referred to the intraoperative management of neuromuscular blocking agent. And the third question was related to the time of recovery. So how to measure a recovery from neuromuscular block, how to treat. And again, there were 5 PICOs. And there was a 4th extra question which was based on the rare or special conditions. You know, if you deal with pediatric, we are used to having everyday rare conditions, so it's a pediatric population is overall a multitude of rare conditions. So the initial idea, which was pretty ambitious actually, was to address how to manage all these relatively rare and special conditions, including neuromuscular disease, cerebral palsy, the use of anticonvulsivant, etc., etc. Okay, so for each of these questions, we allocated 1 leader. I was allocated to question number 3 in order to have a sort of coordination in the overall process. As you remember, we were 21 people participating in the guidelines. So there are basically, again, 3 pillars. 1 is related to intubation, 1 to the maintenance of anesthesia, and 1 to the reversal time, special conditions, and on top of this, how to monitor the 3 steps of neuromuscular blocking agent administration. Oi! Okay, sorry, I touched the wrong button. So the screening, we started with 3,800 papers. Second round, we identified 1,200 abstracts, and then we included nearly 400 papers, full papers, into the overall guidelines. And then once we had all the statements written, we had to go through the Delphi rounds in order to have enough agreement among the overall group of experts participating the guidelines. So, of course, as you know, there is always a threshold of 80%. So we went through 2 Delphi rounds online and a Delphi round in person, which was last year in Munich during the European Society of Anesthesia conference. And I think that I mean, at the end of the day, there was a big debate among the group, but we found a final agreement on statements. This, again, is the modern way to present the guidelines. So in the SOP of the European Society of Anesthesia, these has been recently implemented. So we can offer recommendations which are strongly in favor, conditional in favor, which means that your treatment is strongly recommended, or it's against the specific treatment, or whatever there is no evidence in favor to one or the other treatment, we may say that either treatment can be offered to our patients. And based on this, we had to also identify the strength of evidence, which could be from high to moderate, low, and very low strength of evidence. Okay, let's go into the guidelines. You remember this was the question number 1, neuromuscular blocking agent and intubation. I think the first statement mirrors very similarly the statement we provided in the neonatal and infants airway management, which means we recommend the use of neuromuscular blocking agent to facilitate tracheal intubation in children all ages, so including neonates, which I think is quite strong recommendation. That's why we said it's a strong recommendation based on a moderate level of evidence. The second point is that outside the operating room, surprisingly, there is less evidence. That's why we have to reduce the level of recommendation, saying we suggest using a neuromuscular block for tracheal intubation outside the operating room, assuming that there is enough competencies around on the use of these medications. And finally, there's also a recommendation regarding the rapid sequence induction and intubation, where we recommend switching from the use of succinylcholine into the rocuronium. This is, again, another strong recommendation. In terms of intraoperative, we couldn't find any strong evidence, so we recommended, based on conditional recommendation with moderate level of evidence, that the intraoperative management of the level of paralysis should be modulated according to the kind of surgery the child is receiving. And whenever you're using a laryngeal mask for second generation or third generation laryngeal mask for abdominal surgery, even laparoscopic, the use of neuromuscular block is also, let's say, suggested. So you can use the neuromuscular blocking agent even in case of using laryngeal masks. Third question, residual neuromuscular block. And again, we recommend the use of quantitative neuromuscular monitoring that should be applied to modulate the level of neuromuscular block and to rule out any residual neuromuscular blocking agent residual at extubation time. Again, this is a strong recommendation with a moderate level of evidence. And upon all the different kind of monitoring we have available, we also wanted to suggest the use of ANG as quantitative neuromuscular monitoring to assess intra and postoperative residual neuromuscular block. We recommend the use of sugammadex over the neostigmine, and we recommended to leave the use of neostigmine to selected cases where you already have monitoring and the patient is recovering and you can administer neostigmine. Luckily in Italy we don't have neostigmine anymore, but anyway, the evidence is strongly in favor of the use of sugammadex. And of course, if you remember what Debra already presented, you should modulate the administration of sugammadex or neostigmine based on what? On monitoring, actually, because whenever we are referring to a TOF ratio, it means that you are applying a monitoring in your patient. So it's impossible to provide any recommendation on the dosages of sugammadex or neostigmine if you don't have reliable monitoring on your patient. How about the special conditions? Again, we couldn't find any evidence, so all of these are clinical practice statements just to provide some sort of support. So, for example, we recommend to avoid succinylcholine in children with neuromuscular disease. Sugammadex should be used for reversal even in the special conditions. Neostigmine shouldn't be used in patients with myasthenic disorders. And again, the management should be personalized according to the pathology of the patient. Okay, this is the final visual abstract, which basically summarizes the overall guidelines. Again, is neuromuscular blocking agent necessary to facilitate tracheal intubation? Yes. Whenever you don't need spontaneous breathing, you should use at all ages neuromuscular blocking agent to facilitate tracheal intubation, even in the rapid sequence induction and intubation. Strategies for the diagnosis, quantitative monitoring is recommended, strongly in favor, and the reversal should be based mainly on the use of sugammadex. Finally, which are the strategies? You should use quantitative monitor, the adductor of policies, and the risk of residual block should be ruled out through the use of appropriate monitoring. There is some suggestion to keep prolonged observation in children who had very high doses of neuromuscular blocking agent intraoperative for some reasons. Anyway, so this is mainly based on the paper which Debra showed, and this is written by Francis Wegmans. Again, okay. So as I told you at the beginning, it's also a nice opportunity to see which is the current evidence, which could be the pathway for future research. Of course, we need to understand better which is the physiology and what are the specificities of the use of neuromuscular monitoring, especially in the youngest population. We should understand better about the pharmacology of the neuromuscular blocking agent we are using and the reversal drugs. And ideally, as I told you, considering the rarity of many conditions, we should gather new data through ideally international registries where we report all these rare conditions and how these patients were treated. Of course, the guidelines represent a piece of paper, nothing if you don't implement locally. So that's why we strongly believe in education, educating people, especially the young generation of anesthesiologists, the next generation. We should increase the knowledge of neuromuscular blocking agent, but also the knowledge on how and when to apply monitoring in our patients and how to interpret properly this kind of monitoring. Sugammadex should definitely take over neostigmine. It really represents a game changer in our daily practice. Immediately before publishing the guidelines, we wanted to have a snapshot of the situation in Europe. This was an idea to see if the guidelines will really change the practice. So the survey was launched before having the guidelines out, and we are aiming to repeat a similar survey in 2 years' time in order to see if the guidelines really changed the practice. So we launched the guidelines through the European Society of Anesthesia. This was endorsed by several pediatric societies. As for SOP in the ESAIC, we could keep the survey out only for 1 week. In this week, we had 900 responders, 83% from Europe. And these are the 3 countries which were the top responders. And I show you some of the results, but the overall results will come in another separate publication in the coming weeks. So first of all, the first question was neuromuscular block and intubation, how people manage the adequate condition for tracheal intubation. And you will see here that the 56%, they rely on the time between tracheal intubation, between administration of MBAs and the time you intubate, which is common practice, nearly 60%. Only 20% of people rely on a monitoring. Okay, we can discuss if it is good or not, but anyway, this is actually the reality in many places, including my hospital, where people give neuromuscular block, wait, and then they proceed for intubation. How about the use of monitoring? This was another very interesting question, and to me, I mean, it's more positive than expected. I mean, this is my feeling, because 44% they use regularly quantitative monitoring. 24% they have both. Overall, I may say that 50% of clinicians in Europe, I don't know if it is true, but this is what they said, they use neuromuscular blocking monitoring on a regular basis. Third one, how do you guide your reversal? This is also very interesting, because 50%, probably those that they apply regularly, they rely on the TOF ratio at the end of anesthesia. However, there is still another 50% where they feel that their clinical judgment is enough. The best way to do anesthesia is my way, and I agree. The time interval between the last administration and the end of anesthesia, qualitative monitoring. Anyway, they overall represent about 50% of the daily clinical practice. I think it's a very interesting snapshot, and I look forward to see what happens in a couple of years if we really implement these guidelines and if we are really able to provide adequate education to the pediatric anesthesia scientific community. In conclusion, Debra already presented this paper, which I think perfectly aligned with our guidelines. I don't want to enter into the details of the use of rocuronium, but I want to go to the main table of this paper, which you will see here that if you have no monitoring and non-sugammadex, this was the incidence of postoperative respiratory complications. However, if you are using monitoring and non-sugammadex, you will see here there is a significant drop in the incidence of complication, which I think is quite logical. If you are monitoring your patient, you know when the child is ready to the child. This is adult population, but it applies even for children. And this is the overall summary. So ideally, if you're using monitoring and sugammadex, you should be able, with quantitative monitoring, to zero or nearly zero. It's not zero, but of course it drops significantly the incidence of post-extubation complications. With this, I think we can go to the key messages. Education is the key factor to implement guidelines, and personalized use of medicines, which means neuromuscular blocking agent reversal according to the condition of your patient. So there is no one size that fit in every patient. Monitoring, I think, is the future for personalized medicine, and hopefully we should go outside the operating room with the aim of having global guidelines, which makes sense because what applies in the operating room should apply also outside the operating room. I don't think this is the situation, but this is hopefully the aim for the future. And with this, I thank you very much.